Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Johnson & Johnson.
Hello, I'm Tom Newsom-Davis. I'm a consultant medical oncologist based at Chelsea and Westminster Hospital in London, UK. And welcome to this programme, which is titled Person-Centred Care in EGFR-Mutated Advanced Non-Small Cell Lung Cancer, Optimising Outcomes and Experiences. Now, I'm absolutely delighted to be joined by two of my colleagues. Professor Ginny Harrison, who is a patient advocate for the EGFR-positive Lung Cancer UK, and she's also Professor of Psychology at the Open University in Milton Keynes in the UK. And Gladys Gatchalian, who is a lung cancer specialist nurse at HCA Healthcare UK in the London, UK. Ginny and Gladys, welcome to this programme. So today we're going to be discussing a couple of things. We're going to be talking about individualising treatment for EGFR-mutated advanced non-small cell lung cancer, and how can we optimise outcomes, how can we make the patient experience better. And this is going to include medical oncology perspectives, nursing perspectives, and patient advocate perspectives. And I think between the three of us, we can really cover that well. How do we choose the right therapy for the right patient? How do we manage the side effects of EGFR inhibitor-based therapies? And they've got new developments like subcutaneous formulations. How do those fit in with what we might be doing in the future? So before we get on to that, maybe we'll talk a little bit about the diagnosis of EGFR-mutated lung cancer and how do we ensure that's done properly and correctly. So I'm going to take a couple of minutes just to talk about when should we do this. Now, my view on this is that in someone with a locally advanced to advanced stage non-squamous lung cancer, they should have comprehensive molecular analysis to make sure that mutations, including EGFR mutations, are looked for. Ideally, that would be with next generation sequencing, or NGS, on both a DNA and an RNA-based panel. And that should give you a comprehensive review of the 8 or 9 different mutations we would want to know. Knowing that panel is important. If you are using NGS, then you will probably have very good coverage of all the important mutations. But there are variations in platforms, and it might be that, for example, your institution is still using a PCR-based assay. And although that may be fine, you need to be aware that that can miss some of the rarer EGFR mutations, such as exon 20 insertion mutations or atypical mutations of the G719X family. So knowing what your institution is using and knowing if there are limitations is really important. So in my mind, everyone should have those results done and available before starting treatment where it's medically possible. And making sure that we all do that testing in everyone is very essential. The next time we might want to do molecular testing is actually at relapse. So someone has been on a first-line treatment, they've responded to that, we hope, as long as possible, but then unfortunately things change and the cancer may grow. In that situation, I think there's also an argument to do repeat testing for 2 reasons. One of which is to recheck the histology type, because we know that transformation to small cell carcinoma is possible, and you'd want to know that because it would change your treatment approach. And the other reason is to repeat the molecular analysis, again, hopefully with NGS, looking for new molecular alterations. Now, there may not necessarily be treatments available routinely commissioned in the country in which you're working, but first of all, those may be coming in the future. but also knowing the molecular profile may well give your patient access to clinical trials. So I think it's worth doing. The last thing to say about molecular testing is I focus there very much on tissue testing. The arrival of liquid biopsies or ctDNA or cell-free DNA, these have arrived as well. And in the UK, we are now routinely doing ctDNA diagnosis. This can be invaluable. And certainly the ctDNA gives you the answer of a molecular profile. That's a non-invasive and quick way of establishing it. But if your ctDNA is non-diagnostic, just remember it doesn't give you all the answers. And in that situation, having a tissue NGS panel as well is going to be really important. So that's the very kind of medical oncology bit of what we should be doing when we should be doing it. So I think the first thing I'd like to do is ask Ginny about, from the patient perspective, I think doctors are not very good at explaining we're doing this molecular testing. We know it can be a big weight. Understanding molecular biology of cancers is complicated. Explaining that to patients is difficult. Jim, do you have any thoughts on how we can do better as a medical community in communicating this really difficult area?
Well, I think that the first thing to say is that there isn't a one-size-fits-all here. Every patient will have a different level of knowledge about health, and they'll also want to know probably differing levels of information about their diagnosis and what that means. So first of all, I think you need to really establish where each patient is and meet them where they are and what their information needs are. So I think that's part of it. We've certainly had patients talk to us about things that they've found really helpful. So anything that can turn science into lay kind of terms is better, because you know, for oncologists, this is a language that you use every day. For us, it's like learning an entirely new language. We've never heard some of these terms before. So really explaining in basic terms why you're doing this kind of molecular testing, what it's for, and how it guides treatment is really important. And that might be using analogies like molecular fingerprints or something like that can really help. So I think the other thing to note is that initial period, a lot of patients really describe it as like being in limbo and not knowing what's happening, and that uncertainty. You can't really underestimate the impact that it has on mental health and well-being. So really explaining the timeframes, you know, the fact that you need to wait for these results because that will guide you to the best treatment is incredibly important. And I think just making that really clear to manage those expectations and uncertainty would be really, really helpful for patients as a whole in terms of quality of life as well as anything else.
And presumably saying to someone, the most important thing we can do is get the best treatment as your first treatment, and it's better to wait and get the correct treatment than not wait and get the wrong treatment. That kind of approach presumably may be helpful to try to say why you are waiting.
Absolutely. And again, you know, really explaining that in simple terms. It does feel like forever when you're in that initial period. It might feel like only a matter of days to you, but for the patient, a matter of days is huge. So I think just being really clear about why you're doing it. We know that a lot of patients feel that they don't really have that much information at the beginning. And that might partly be because they're in shock. It's very difficult to take in that information. So another tip I'd have is if they've got a carer or a loved one that they can have with them, have them in the room, because actually they'll probably remember quite a lot more about those conversations than the patient will. So that's another kind of tip that I would suggest.
I think that's absolutely right. Then, unfortunately, we are often rebiopsying at progression. Now it's changed because we hope that patient has been on treatment for a considerable period. They will know their team. Hopefully it will be slightly less terrifying. But having perhaps been on a treatment for a while and feeling well, then you're faced with prospects of invasive biopsies. What's your take on that? How welcome or unwelcome would that be? And what should the healthcare professional be thinking about when broaching this subject?
Again, I think it's about, you know, it's very similar to the beginning because it is, again, it's a bit of a shock when it happens. So right back to diagnosis, being quite clear about the fact that these targeted treatments often, you know, that they don't last forever. So it's not a complete shock when it happens. And again, explaining that there might be a reason why the cancer's mutated around it or has become resistant to it. But I think also being honest about the fact that there is uncertainty, because again, it's a huge time for people in terms of psychological impact, and uncertainty underlies a lot of the kind of anxieties that we have. And I think making sure that they're aware of what those different options might be and that they can be involved in those options and those decisions, I think that's really important.
I think that's absolutely key. I've certainly made a mistake over the years of hanging everything on the mutation and people thinking if they don't have that, they can't have treatment. So I now say beforehand, if we find something, that's great. But if we don't, there will also be other treatments. That's really helpful. Thank you, Jean. So I'm going to move on to maybe frontline treatment selections and how we choose different treatments for patients in the advanced stage disease with an EGFR-mutated lung cancer. I'm just going to briefly overview that because there have been changes over the past 2 or 3 years, and they're really important changes. So until recently, we would have been using single-agent EGFR inhibitors, and there have been many of these over the years, but I think it's fair to say that of late, osimertinib would be seen as the standard of care pretty much across the world. And that remains the case. There is still a good argument to be giving single-agent osimertinib to patients with common EGFR mutations in the advanced stage setting. More recently, we've had some combination regimens come through. One is called Mariposa, and that is a combination of lazertinib, which is a bit like osimertinib, an oral drug targeting the EGFR mutation, but also an antibody-based treatment, amivantamab, which is targeting EGFR and MET. So using these both together, the Mariposa regimen is one alternative, and that has been shown to improve progression-free survival and overall survival in patients with advanced stage common EGFR-mutated lung cancer. The alternative approach is the FLAURA2 regimen. So this is osimertinib, this time combined with chemotherapy, pemetrexed, and carboplatin. That has also been shown to improve progression-free survival and has also been shown to improve overall survival. And although cross-trial comparison is something we should be very careful about, I think it's fair to say that in terms of the efficacy, progression-free survival and overall survival, FLAURA2 and Mariposa, very similar overall. We await more mature data. In the second-line setting, after osimertinib, then there are additional options. Probably the most standard at the moment would be seen as chemotherapy, pemetrexed, carboplatin, but an additional regimen, Mariposa 2, has also come on the scene in the past couple of years, and this is pemetrexed, carboplatin, and amivantamab. I should point out that's licensed after use of single-agent osimertinib. So those are a possibility in the second-line setting. So, going back to Ginny, if I could, when I'm trying to explain those options to a patient, I've got in my mind possible single-agent osimertinib, maybe chemo and osi, maybe if I had access to it, amivantamab and laser. How do I explain that, and how should colleagues approach this really difficult bit? We're keen to inform people, but we don't want to confuse them.
No, again, I think it's simple transparency in whatever terms, but I think what we know from patients is they do want to be involved in those decisions, but actually one of the biggest barriers to that is the complexity of the information. So anything that can be done to really strip that back. Let's not talk about adverse side effects being grade 2. Let's talk about, okay, but what does this actually look like for you, or for me as a patient, as an individual? I think that's really important, bringing it to the real world effects, because what patients really care about is, yes, of course, they care about longevity. They want to live longer, but most people also value quality of life at sort of an equal weight, some even more. So I think really understanding what the impact of these different drug combinations is going to mean in terms of side effects. What will that look like for my daily life? What will that look like for how many times I have to go into hospital, for example, because that's a big thing for some patients, for others less so. And again, there's no one size fits all. There's not going to be one answer that every patient is going to say. So it's about finding what is it that's really important for each individual and helping them make that decision, working together in that shared decision-making process.
Sources of information in the UK, in my practice, we use Cancer Research UK, CR UK consent forms. We use Macmillan information sheets, which I think are great, but they're still pretty text heavy. We know the average reading age in the UK, the adult reading age, is around 9 years. We know that most NHS information is written at the reading age of a 16-year-old. So they're disparities there. What about the use of other approaches? I guess online videos, cartoons, graphics, can these be helpful?
Absolutely. And actually, patients talk about, even when you've got your oncologist in the room with you, drawing diagrams of different things and timelines or images of lungs, that comes out again and again from patients as being really helpful. But you'll find a lot of the patient charities, that a lot in the UK anyway, have produced alternative formats for information to make it more digestible. So that might be animations, which is really trying to take that really complex information and break it down and get it across in real lay language that's better to understand or easier to understand.
And there's been some excellent work done by Luce. Lung Cancer Europe have done a report recently. This is their 9th report, I think it was published in 2024, looking at shared decision making. And I would absolutely point any colleagues towards the Luce reports. They're available free online, they're beautifully written, they're very clearly presented, and it can be very helpful for clinicians to go through that. So I'm going to move on now a little bit to managing side effects. So we're going to transition from the information we've given someone, the testing we've done, we've discussed the various options, and we're now going to arrive at a treatment and just talk a little bit about that. Now, what we know about EGFR inhibitors is that there are some similarities in side effects. EGFR, of course, standing for epidermal growth factor receptor. We do see there are often mucocutaneous side effects, skin and GI being perhaps the most common. And as newer agents have come through, we have been faced with newer and more challenging possible side effects. So osimertinib we're very familiar with. We've been using it for many, many years. And we know the common side effects would be rash, diarrhea, and nail changes, including paronychia. Usually the rash and diarrhea manageable, the diarrhea usually intermittent. There are some rarer side effects, including effect on cardiac function and risk of pneumonitis. The newer agents, such as lazertinib and amivantamab, have slightly different profiles. So lazertinib still has the rash and diarrhea aspect of osimertinib, but less likely to cause cardiac side effects, a little bit more likely to cause paresthesia and also muscle cramps as well. Amivantamab, on the other hand, does have a different spectrum of side effects. It can cause infusion-related reactions during particularly the first and sometimes the second dose in the intravenous form. It can cause the skin effects, which are often more marked, and it can have different skin effects, including that affecting the scalp, which can be particularly problematic. And I think it's the amivantamab-based side effects we need to think about slightly differently, because our approach to managing side effects in patients on amivantamab-based treatment does need to be different to that which we've been routinely doing for example, osimertinib-based treatments. So I'm going to go turn to Gladys, and we're going to think about skin initially, Gladys. You and I have had many patients over the years, and I think we've become expert at managing this. We've learned with amivantamab-based regimens that we've really got to get things going almost before people have started. Could you tell us about the regimen you recommend for patients to use with amivantamab-based treatments, the Cocoon regimen? What does it involve, and what do you advise patients?
So the Cocoon regimen that we use for patients would improve the situation of the patient, and we have different medications that we administer to patients that will reduce the toxicity. This composes of the doxycycline, and we use the chlorhexidine, 4% of that as well, and we give the doxycycline for about 12 weeks on the treatment, starting on the day of the treatment, and also for the ceramide moisturizers that we then give to patients or advise patient, and it's making sure as simple moisturizers as possible, because at least it's not going to complicate or have any reaction to the medication, the amivantamab. And
I think getting on with those, the chlorhexidine washes, the doxycycline, for example, getting them going before or at the point of treatment is really important. We also give them general skincare advice. Avoiding strong sunlight, using strong sun protection is important.
But also, Tom, I'm just gonna emphasize that this cocoon study, they are not going to reduce the onset of the paronychia. So it just have to be emphasized that with patients, and we need to make sure that we assess that properly as well.
Absolutely. And so I think the evidence behind cocoon is interesting. It's reducing skin rashes, it's reducing scalp side effects. It's not significantly affecting paronychia, which can be a problematic side effect. Something which we tend to manage with swabs, with topical creams, topical antibiotics, often including steroids as well. So that's our approach towards the skin toxicities. We've also got GI toxicities, principally, of course, diarrhea. What are you advising patients, either with amivantamab or with oral therapies like lazertinib or osimertinib, about how to manage potential GI toxicities?
Initially, I will assess obviously with their normal regime. For example, some patients are not going every day. Some patients are having already loose stool, for example, even starting off the treatment. So we just have to record that. And then if, for example, they have loose stools, as long as it's not watery, for example, we advise them to take the antidiarrheal tablet, loperamide. And what recently that I've noticed with patients is that when they change the regimen of taking the osimertinib to take the osimertinib in the evening, and then take the loperamide, or the vice versa, it depends on how it works. So they just have to make sure which one that works with them for the antidiarrheal tablet.
I think that's right. And it's interesting, isn't it? Changing the timing of the osimertinib, for example, can certainly affect timings of diarrhea and therefore tolerability. I think grading is important. We want to know how severe it is. The thing I would say is that although I think oncologists often sit in meetings and say, oh, it's just grade 2 diarrhea, grade 2 diarrhea is really unpleasant. And I don't think low grade means we shouldn't manage that side effect. And remember, low grade diarrhea is still unpleasant. So those are the GI ones, and I think you're right that focusing on loperamide is key in excluding other causes. What's specific to amivantamab are the infusion-related reactions. Now, as a lung community, we haven't really seen these before in our drugs. This is when we are giving amivantamab intravenously. But there is an approach to minimizing this called the skipper regimen after the trial. Gladys, what's involved in the skipper regimen? What should people be prescribing? And how effective is it at reducing infusion reactions?
We've seen that in the trials, Tom, that it's really reduced the infusion-related reaction to patients. So we'll make sure that we are going to give the dexamethasone, 8 milligrams, the high dose of the 8 milligrams, 2 days before and on the day of the treatment. And it's proven, I've seen that really reduce the infusion-related reaction. And also we have admitted patients as well. We have to make sure that they are admitted for the next 2 days because of this infusion-related reaction, though it really have now improved patients with all this medication, the dexamethasone that we give to patients. So I think that's the main thing that we have to.
And just to clarify, it's 8 milligrams twice a day orally for the day -2, day -1, and on the morning of treatment. It doesn't
5 doses, yeah.
Yeah, it doesn't reduce the incidence of other side effects, but it does reduce infusion-related reactions. There are some changes to what's going on in how amivantamab can be given, and there are subcutaneous formulations which are now licensed and are coming into clinic. We're also seeing subcutaneous formulations of other drugs, immunotherapies such as atezolizumab, pembrolizumab, and I think the subcutaneous therapies is quite interesting. If we were to focus on the Paloma study, which is a subcutaneous formulation of amivantamab, we've seen that can reduce infusion-related reactions. It doesn't seem to have a significant impact on other side effects, but that reduction in infusion-related reactions is helpful. Subcutaneous formulations of themselves, this is quite new in lung cancer, and we may be able to move some patients away from intravenous treatments. Shinny, from your view, from your perspective, how much better is a subcutaneous formulation than an intravenous one? What benefits might it bring, but also what disadvantages or other lack of benefits might that bring?
I think it has the potential to make a big difference in terms of the amount of time potentially spent in hospital. At the moment in the UK, you still do have to go into hospital for subcutaneous injections. You know, whether you're having it IV or whether you're having it subcutaneously, you still need to physically go into hospital. Potentially that will reduce that amount of time spent there, which might be really important to patients. And as you say as well, it is really reducing the infusion related reactions, which I know a lot of patients have heard about and are quite scared about. So there is that aspect as well. And there's the travel time and all your appointment times and everything else. But actually that infusion time is much, much lower. So I think a lot of people might be really pleased to have it that way rather than through an IV.
Yeah, thank you very much. And I think, at the moment we don't do community administration. It is done in the breast cancer world with a number of breast cancer drugs, and I wonder whether in people who are stable on treatment, it might be something we can look to in the future. Gladys, from the specialist nurse point of view, what are there any particular considerations of subcutaneous formulations? And these are often things given over a few minutes. What's your perspective on that? What's your perspective on patient experience of subcutaneous versus intravenous?
I think, Tom, that will be a very it's given for seven minutes, and it's no longer going to observe for the infusion related reaction. So it's also a big impact for the outpatient, if that's the setting for that, and then the turnover of the availability of the chair or the bed that will be for the next patient to occupy that chair.
I think that latter point is really important. There's a national and there's an international shortage of chemotherapy nurses. We have huge pressures on our chemotherapy units. If we can have more efficient use of chairs and more people being able to use one chair, that's got to be a good thing. So I'm going to kind of bring this to the end. Ginny, Gladys, what will be your final thoughts? Ginny, perhaps you first, take-home messages on kind of practical guidance for doctors and nurses listening to this regarding patients with EGFR-mutated lung cancer.
I think the first thing is that when you're talking about a patient, you're talking about an individual who's a whole individual, and we're not just talking about somebody with cancer and that's it. So we really need to think of each individual as a whole and think about what's important to them, what will they or won't they be happy with in terms of impact of quality of life, and also in terms of the psychological effects, because I think that they can be really, really significant, particularly at the beginning of diagnosis, but also on progression and often throughout the whole journey. We know from a survey that we've done at EGFR Positive UK that using clinical cutoffs, 1 in 4 have clinical levels of anxiety and 1 in 5 have clinical levels of depression, which is much higher than that you see in the general population. And going back to the Luce report, so their 10th report on mental health, that shows that, the majority of patients do have a significant negative impact on their mental well-being. Yet about half of them feel completely unsupported. And the other thing I think that's important is there are a lot of support networks available out there. There's a lot of charities out there, and specific charities for specific cancer types like EGFR. And so really knowing those is important, because often they give that kind of peer support, that information that patients can really find very helpful. So knowing about them and directing patients to them is really important and can help alleviate some of the mental burden of the disease as well.
That's really helpful. I agree with all of that. Gladys, what's your any take-home messages from you?
I think the most important thing is that the patient's education, not only patient's education, as mentioned by Jeannie earlier on, we have to educate the family members as well, because there might be too much information for the patient on that day. And so at least there's someone who's also watching them. So the main carer, the next of kin. Education for my team as well, so they know what to watch. Important thing as well is that they have to report as early as possible for their side effects, so that we can tackle that problem, and rather than having it at the end and making it too late to to address that issue. So as long as we have that good communication, reporting, and also from my part as well is that to assess my patient, to have the follow-up as well, to make sure that I am following up all the side effects of that, especially for the skin toxicity. So then we can also do a dermatologist referral so that we can all have that partnership in looking after these patients.
I think that's absolutely right. I mean, early recognition, early reporting, and making sure that we make ourselves available to our patients, I think is absolutely central. So I think that kind of takes us to the end. So what's my key takeaways? My key takeaways are that with EGFR-mutated lung cancer, the first step is to make sure everyone is getting comprehensive molecular analysis so that if that person has an EGFR mutation, even an uncommon EGFR mutation, we know about it. When you're discussing and choosing options, there are a number of those available. Single agent osimertinib with chemotherapy, lazertinib, amivantamab in the first line setting. And any of those are very reasonable treatments. And when we're going through that with patients, we need to think as healthcare professionals how we best explain this to make it understandable, to make it digestible, and so that it can be a joint decision. We need to think about rebiopsying patients who have progressed on first-line therapies, because there may be different second-line approaches in that scenario. When we are thinking about management of side effects, the common ones are cutaneous and gastrointestinal, and with amivantamab-based treatments, also infusion-related reactions. Early recognition and early treatment of side effects is by far the best way. And there are some particular approaches to amivantamab-based treatments, the Cocoon skin regimen and the Skipper infusion-related regimen, to minimize those respective side effects are really important. So I'd like to thank Ginny and Dadis for joining me today to give their expert opinion, and I'd like to thank you, the audience, for joining us as well. Thank you very much.